Thank you. So contrast-enhanced mammography is also known by contrast-enhanced digital mammography and more so by contrast-enhanced spectral mammography, which is a name given it by GE. These are all different names for the same thing. So what is the motivation for contrast-enhanced mammography? Well, we know mammography is great at screening, it's fast and low cost, but it is not perfectly sensitive. MRI, on the other hand, finds almost all the cancers, and that's because it uses a contrast agent, but it's expensive. So the idea of contrast-enhanced mammography is that it would be like MRI in terms of finding cancers due to the contrast, but like mammography in terms of cost. But it's much harder to show contrast on a projection technique like mammography as opposed to CT and MRI. In addition, when you're dealing with mammography, you're compressing the breast, and that decreases blood flow and makes contrast uptake less. So we need a way to use subtraction to increase contrast visibility, and ideally a way to not compress the breast during the contrast injection. So to do this, we use the technique of dual energy subtraction. And in this, both images are acquired after contrast injection. And one of the images has a higher X-ray energy than the other. And iodine absorbs the high energy beam better than does breast tissue, and breast tissue absorbs the low energy beam better than iodine. And what happens when you subtract them is that the breast tissue subtracts out and the iodine is left on the image. It may be a little confusing if you're not familiar with it, but I will show you some examples. For contrast-enhanced mammography, the advantages of dual energy subtraction are that you can image both breasts in multiple projections. If you were doing regular temporal subtraction, you would be limited to one view of one breast. And you can image with full compression because you do the injection before the breast is compressed. Additionally, the images are obtained only seconds apart, so you don't have the issue of misregistration like you would if you were doing a pre and post contrast subtraction, and that gives you improved morphology information. Here's an early case from my first study, and what you're looking at is the standard mammogram, and you can see that the tissue is very dense. What you don't know is that the patient came in with a palpable abnormality that was suspicious on ultrasound. So we enrolled her in our study and did a contrast mammogram, and the contrast mammogram is this. So very hard to see the cancer on the left-hand image, but extremely easy on the right-hand. Here's a slide showing what's happening with that case. The left and right-hand images are the same as you just saw, but the middle image shows what happens if you do dual energy subtraction before you inject contrast. And so the dual energy is what's causing all of the glandular tissue to appear subtracted. When we do it after iodine injection, we see the tissue subtracted and we see the cancer. So here's some early dual energy papers. Our paper came out in 2003, and we did it using a standard mammography device by putting aluminum filtration in front of the beam. And we had 26 subjects, 13 of whom ended up having cancer. These were all BI-RADS 4, and all the cancers enhanced. Then a couple of years later, GE helped build a prototype, and Dr. Diekman et al. In Berlin did a similar study, 25 lesions, about half of which turned out to be cancer, just as in our study. And again, all the cancers enhanced. So here's the table summarizing 4 early papers comparing contrast mammography to standard mammography, and as expected, contrast mammography was superior to standard mammography in all of them, with sensitivities in the low to mid 90s. Early on, it was clear that contrast mammography is better than regular mammography, but what about its comparison to MRI? So here's a case of a patient who came in to the University of Colorado with a cancer, and the cancer is shown as architectural distortion in the upper outer breast on these 2 mammograms. There's a scar marker, and originally at the outside institution, the readers had thought that the architectural distortion was due to scar, but it's clear on the CC view that it doesn't correlate to the marker. I also labeled a round mass on the MLO view that is a cyst. So here is her MRI, and you can see on these slices that go from lateral to medial, that she has cancer surrounding the cyst in the lateral breast, and then medially also cancer, and in between there's a focus of cancer posterior centrally, which you can see right here. So compare that to this study, which is the dual energy subtraction MRI, and you see the same thing, cancer surrounding the cyst, and most of the cancers in the lateral breast. There's a little focus right here, and then some cancer in the medial breast. So quite equivalent. So this was studied systematically by a number of authors and has continued to be, but the early papers were really these two. And in both these cases, they took patients with a known cancer and did both MRI and contrast mammography on them. And the Fallenberg paper had 80 subjects, and the sensitivity was actually higher for contrast mammography than for MRI for the index lesion. Contrast mammo found all 80 out of 80, whereas MRI found 78 over 80. That difference is not significant. In Maxine Jokelsen's study at Sloan Kettering in New York, 52 subjects, and the two techniques had equal sensitivity, 50 out of 52 of the index cancers. MRI did have better detection rate for additional lesions. It found 22 of 25 versus 14 of 25, but that came at a cost of higher false positives. Contrast mammo had fewer false positives than MRI, 2 versus 13. Another paper in 2015 that I worked on was Dr. Zhou from Taiwan. We had 255 cases, 80 of which were cancers, and we looked at both contrast mammography and a prototype technique called contrast-enhanced tomosynthesis, where we combined dual energy imaging with tomosynthesis. We actually did high and low on every other projection image. And we did an RC study, and we found that MRI, contrast mammography, and contrast-enhanced tomo were not significantly different. So we didn't find an advantage to contrast-enhanced tomo over regular contrast-enhanced 2D mammo, and equivalent, and also MRI was the same. Now, all of these techniques did better in the RC study than mammography, tomo, or ultrasound, even when those three were combined. So this table summarizes 6 of the papers published between 2013 and 2016, and they all had very similar results with sensitivity of contrast mammography and MRI in the high 90s. A couple of them showed MRI sensitivity a little bit lower, and the few that did ROC were variable. 1 showed it equal and 2 showed MRI to be better. Here's an example of contrast mammogram this is from my study with Dr. Zhou. The mammogram's on the left, the appropriate tomo slice is in the middle, and the contrast mammo is on the right, and you can see that the lesion enhances very brightly. CC view shows the same thing. Here's the MRI, which shows that the MRI appearance is very similar. It's circumscribed, rapidly enhancing. At this point, there have been enough studies to do meta-analyses. 3 have been published. The latest was this year by Kozia and al. 60 studies were looked at with 11,000 contrast mammo examinations, and they determined that the average sensitivity in all these studies was 95% with a specificity of 81%. So quite good and similar to MRI. There have been several papers looking at diagnostic uses of contrast mammography, and one of these I'd like to highlight is neoadjuvant therapy monitoring. So 3 papers at least have come out looking at contrast mammo for neoadjuvant chemotherapy monitoring. It is attractive because you would expect it to be quite good, and it would be lower cost than MRI. One of the papers was by my colleague at the Mayo Clinic in Arizona, Bhavika Patel, and she shared some slides with me, which I'll show you now. Here is one of the cases that was included in her paper. This is pre-neoadjuvant therapy, and on the left is the mammogram, in the center is the contrast-enhanced mammogram, and on the right is the MRI, and you can see that they're all very similar. Here are the equivalent images after the completion of neoadjuvant chemotherapy, and you can see on both the contrast-enhanced mammogram and the MRI that the tumor has disappeared. And in the published literature, including Dr. Patel's paper, MRI and contrast mammo had very similar results. Both were highly accurate with a slight tendency to overpredict complete response. So where does contrast mammography stand today? Well, there's 4 approved devices, with GE and Logic being the 2 that are actually being sold. It's in clinical and or research use in about 30 countries, and already published is the contrast enhanced mammography update to BIRADS. I'd like to briefly talk about future directions, and the biggest innovation this year in contrast mammography is the introduction of biopsy directed by contrast mammo. I'd also like to talk a little bit about screening, which is a potential future application. So both Logic and GE have approved devices for CEM biopsy. They're currently being evaluated at a limited number of sites. Both use similar technology based on their upright stereo biopsy devices. Initial results were published from a group in Barcelona using GE equipment, and there's the reference. And here are some images from their paper, and as you can see, they include both the low energy image and the subtracted image, and they're the equivalent images to what we would do now in an upright stereo biopsy. Here are the results of their study. They looked at 66 lesions from 64 patients and were successful 63 out of those 66 lesions. 3 of the lesions didn't enhance. They were able to biopsy 1 of them anyway because they could see it under tomo. The average procedure time was 15 minutes. A few words about using CEM for screening. So MRI works well for high-risk screening, so you would expect CEM would as well. CEM has some potential advantages, namely lower cost of equipment and shorter exam time, which makes it a lower cost test. An extra bonus is that with CEM, you also get a regular mammogram in terms of the low energy image. So that image has been shown in multiple studies to be equivalent to a regular mammogram. So you can use it to find calcifications. Whereas with MRI, typical screening is MRI plus standard mammography. There have been 3 studies published looking at CEM for screening. I have one of them on this slide, which is the only prospective study. It was done at Sloan Kettering, and they enrolled 307 women and found only 2 cancers, primarily because these women had been well screened in previous years with MRI. But both CEM and MRI detected both of the cancers, and mammography detected neither one. And the specificity of CEM and MRI was equivalent, which is important because false positives are an important part of screening. The 2 retrospective studies are summarized on this slide. One was done at Sloan Kettering by Sung and found 15 cancers in 904 women. Only 8 of the cancers had been seen by mammography, so that's the equivalent of 7.7 per 1,000 women. The other by Soren found 21 cancers in 611 examinations. Mammography found only 11 of them, so an equivalent of 13.1 additional cancers per 1,000 women using CEM. We will need large prospective trials to prove that CEM works for screening, and there's at least one underway now, which is being done by Akron, and it's called CMIST. It's using GE equipment only, and it'll be comparing contrast mammography to DBT, or in some cases DBT plus ultrasound. So to summarize, CEM has some advantages over MRI. It's lower cost and faster, it's easier on the patient, it has fewer false positives, and it's a single exam for high-risk screening, as opposed to MRI, which requires a mammogram to detect calcifications. We now have contrast-enhanced biopsy. MRI, on the other hand, includes more of the chest wall and the axilla, as well as the entire breast. It is better at showing small amounts of contrast. Gadolinium may be safer than iodinated contrast. MRI has no radiation, and of course it also has biopsy. And thank you for your attention. I hope that this brief overview of contrast mammography has been helpful.
Thank you, Dr. Lewin, very much for your interesting lecture. Unfortunately, we don't have any time for discussion. We've been informed that the Minister of Health is on the way now, or he's almost arrived.